So anytime we are looking at treating the sacrum, the SI joint, there's really three areas that we need to always make sure that we're looking at. That's the lumbar spine, the sacrum itself, and the innominate, the pelvis. Oftentimes, if people are having a hard time getting corrections at the sacrum, a lot of times it's because they haven't fully addressed things that may be going on at the pelvis that could be holding the sacrum from correcting. One of the most common dysfunctions that we oftentimes see at the pelvis is what's called an anterior ilial rotation, or an anterior pelvic rotation. And simply when the innominate itself is basically just kind of stuck or pulled or held anteriorly rotated. I'm going to show you a technique to correct that. These are very, very common. There's a lot of different ways that you can correct it. I'm just going to show you simply one way that I've found to be very easy to do. So to correct an anterior pelvic rotation, if the innominate is rotated anterior, to correct it, I simply just want to pull it back posterior. So I'm going to do this using a direct MET, a direct muscle energy technique, where I'm going to basically facilitate the hip extensors to pull the innominate back posterior. To do that, the very easiest way that I found is to just simply sit on the table and then just rest my patient's leg on my shoulder here. This makes it nice and easy to support them, and my hands are nice and free to do a lot of other things. First thing I'm going to do is just reach across and palpate my patient's opposite ASIS. Okay? I'm going to palpate at his opposite ASIS. I start with the leg down nice and low, so I'm not already past his first tissue barrier here. I'm going to simply just flex his hip up until I feel a little tug or a little tightness at the opposite ASIS here. And you'll feel the restriction fairly simple. From there, I'm just going to bring my hand from the ASIS. I'm going to bring it down onto his mid-thigh here. Now, my other hand is on the back of his hamstrings here. I'm going to facilitate his hamstrings. His right leg is going to push into hip extension. His opposite leg is going to push up into hip flexion here. So I'm going to get a counterforce on the other side. My cues, I like to keep my cues very simple. Mike, don't let me push your knee towards your head. And push up into my other hand. There you go. I want to hold for 6 to 10 seconds. That's a very important time frame there to get the neurophysiological change that we're looking for. So 6, 5, 4, 3, 2, 1, and relax. It does not have to be a hard contraction here. It's just a moderate force. Moderate force is really all that's needed. Okay? We just gained some motion. So I'm going to go back up to the ASIS. I'm going to palpate as ASIS, and I'm going to take up that new slack that we just gained. So I'm going to flex his hip further up into flexion until I feel the next little tissue tension. I'm going to drop my hand back down onto his other thigh and simply push both legs into my hands. Good. 6, 5, 4, 3, 2, 1, and relax. He relaxes. We're going to do 3 cycles of this. That was our second cycle. I'm going to come back up to his ASIS here. We gain motion, so now I'm going to take up that new slack. As I continue to flex his hip here, I want to be mindful of his hip and make sure to avoid getting impingement in the front of the hip there. I'm going to abduct his leg a little bit. I can externally rotate it a little bit just to kind of clear the hip there, make it feel more comfortable for him. Okay? We just brought him up until I felt the next little tissue tension at the opposite ASIS. And now, once again, he's going to push both legs into my hands. 6, 5, 4, 3, 2, 1, and relax. Very well. We just finished our third cycle there. We gained some more motion, so I'm just going to simply take his leg and just kind of take it up into that new slack right there. Just kind of let his body know, hey, it's good to go up here. We just got this new motion for you. It's good to go up there. Okay? And then I'm going to bring him back down. So to review, the involved leg is going to push into hip extension. The uninvolved leg is going to push up into hip flexion. So there's a counterforce on the other side. What's really nice about this technique also is that if you thought that the right side was anteriorly rotated, but in fact actually the left side was posteriorly rotated, you'll still get a correction out of this because the other side is pulling the other innominate from a posteriorly rotated position back into an anteriorly rotated position. The nice thing is with using these techniques is that there's no way that you can create a dysfunction if something is not there. So it's a nice fail-safe. So either way, you'll get a correction with this.